year-old male who's a resident of Delhi. Patient is a post-renal transplant recipient since the past 5 years. He came to our OPD with complaints of fever, burning micturition, and fraud.
Yes, please go on. 42-year-old
male, resident of Delhi, post-renal transplant, 5 years.
Okay.
And he came to our OPD with complaints of fever, burning micturition, frothy urine since past 15 days, and swelling over feet since past 7 days.
Yes.
The history of present illness. I would like to date back my history 10 years back, when during a routine evaluation, patient was found to have a raised BP of 150 by 88. At that time, he was completely asymptomatic and he was advised by doctor to get a regular checkup. In the checkup, his complete blood and urine workup was done and all reports were found to be normal. There was no history of hematuria or frothy urine at that time, no history of fever, burning micturition, or any symptoms suggestive of lower urinary tract symptoms, no history of sore throat, cough, or hemoptysis. The doctor advised him dietary and lifestyle modification and asked him to be on regular follow-up. The patient initially went on to have regular follow-up and used to check BP at home with dietary modification, but later on he was lost to follow-up, and for the next 2 years he did not measure his BP. 2 years later, when he again visited the doctor, his BP was checked and it was found to be 180 by 110 at this time. The doctor advised him few blood tests and it showed that the creatinine at this point was 2.2 and his urine examination showed leakage of blood and protein. He was referred to a nephrologist at that time and some medications were started, BP medications were given. But the situation continued to worsen. His creatinine increased from 2.2 to 4.4 and then he was advised admission and a kidney biopsy was done. The procedure was uncomplicated, and after the procedure, patient was given some IV and oral medications, the nature of which are not known. On the follow-up, the creatinine continued to rise, and in the next 1 year, it increased from 4.4 to 6.6. There was no history of any indigenous or alternative medication intake, no history of NSAID use during this time, no history of joint pain, weakness, any eye or ear complaints. There was also no history of swelling over feet, abdominal distension, hemoptysis, cough, breathlessness, or any history of reduced urine output. Over the next 6 months, patient condition worsened. He developed swelling over feet. There was reduced appetite, episodes of vomiting, and creatinine increased to 15 mg%. He was therefore initiated on hemodialysis with a right neckline insertion, and 2 sessions of dialysis were done on consecutive days. Later, an AV fistula was made on the left radiocephalic vein, and he was put on regular maintenance hemodialysis of 2 per week. His residual urine output during this time was 1200 ml per day. The left AV fistula matured over 6 weeks. The jugular catheter was removed, and his dialysis was continued through the AV fistula. He was given some oral medications for calcium phosphorus control and injection erythropoietin for anemia control. During dialysis, his blood flow was generally in the range of 250 to 280 ml per minute. He does not know the dialysate flow. Every time he used to have a fresh dialyzer use, and his intradialytic weight gain was around 1 to 1.2 kgs. Patient has a dialysis vintage of 2 years. During this time, he did well. He had a normal appetite. He used to have normal lifestyle. He also used to visit hospital. He was working in his office. There was no history of any admissions during this phase. No history of any hypotension or hypertension episodes during dialysis time requiring any admissions. 2 years later, patient had an ABO compatible kidney transplant, donor being father-in-law with same blood group being B positive. On the initial workup, patient was found to have some sensitization against the donor, so injection rituximab was given 10 days prior to surgery, and ATG induction was given on the day of surgery, and later he was put on triple immunosuppression. Patient was discharged at day 7, and his discharge creatinine was 1.5, which later reduced to 1.12 over the next 3 to 4 years. There was no complications during this time. Drain was removed in 4 to 5 days, and he was compliant on his medications. Patient had been on regular.
Before you just one sec, before you go further,
Yes, sir.
the biopsy report is available.
Sir, he knows the biopsy. Yes, sir.
Okay, so you can tell us the
Yes,
details of the biopsy right now.
Yes, sir. Okay, should I tell you the report?
Yeah.
Okay, so just the patient had the previous biopsy report with him, and yes, sir. The biopsy, one linear core, 0.7 centimeter in formalin and 0.8 centimeter in saline. Another second core. There were multiple sections stained with HNE and PAS. So this is the native kidney biopsy.
Yeah.
Yes. So there were 10 glomeruli, 50% were globally sclerosed. Remaining glomeruli appear enlarged, diffuse, variable, mild to moderate increase in mesangial matrix and cellularity. Occasional glomeruli show intracapillary and mesangial polymorph infiltration, endocapillary hypercellularity. 3 glomeruli showed segmental tuft sclerosis, solidification, proliferation of extracapillary cells comprising of both parietal and visceral cells forming crescents and pseudocrescents. The viable peripheral glomerular capillaries did not appear thickened. IFTA was 40% in the sampled cortex. Viable tubules show cytoplasmic vacuolar changes and patchy acute tubular injury. Few tubules showed needle-shaped cholesterol crystals. Arteries showed medial thickening, fibrointimal sclerosis with duplication of internal elastic lamina. Sir, DIF was done. It showed presence of IgA 2+ to 3+, C3 2+ to 3+. Kappa lambda was equal. So a diagnosis of mesangial and focal endocapillary proliferation with secondary segmental sclerosis was made, with IF suggesting IgA nephropathy with patchy acute tubular injury.
Okay, this was reported from where?
Sir, Dr. Alok from Dr. Lalpath.
Lalpath. Okay.
Yes.
Right. So, is there a MEST scoring available?
Sir, actually, this was done previous MEST score, sir. He hasn't mentioned in this actually.
Okay. You are aware of MEST scoring for
yes, sir.
IgA nephropathy.
Yes,
so what?
Yes, sir.
What are the other components of this scoring?
Sir, in MEST C scoring, there is mesangial hypercellularity. There can be present or absent. Endocapillary hypercellularity present or absent. Segmental sclerosis present and absent. Tubular atrophy less than 25%, 25 to 50%, more than 50%. And presence of crescents less than 25%, 25 to 50%, and more than 50%.
Yeah. So that is the MEST scoring. In the earlier classification, crescents were not included in this scoring. So later on, the crescents were also added in this scoring. So it became MEST C because of the addition of crescents in this.
Right, sir.
Okay. So there's no doubt about the basic diagnosis. So it was IgA nephropathy, and this patient progressed to end stage within a period of around 5 years after the first time when he was found to be hypertensive.
Sir, around 2 years. 2 years.
2 years only? Okay.
Yes,
he remained on dialysis for 2 years. Yes, I forgot that.
Yes.
Yeah. So 2 or 3 years only. So relatively rapidly. What is the usual course of IgA nephropathy?
So usually IgA nephropathy has an indolent course. Young males are found to be affected, and generally they present with hypertension with microscopic hematuria. The progression of disease is slow. Around 20% over 20 years go into end-stage renal disease.
Yeah. So generally, it's a slowly progressive disease in the vast majority. However, there can be patients like this in whom it progresses more rapidly. So this would also depend on the blood pressure, the severity of the presence and severity of the hypertension. So if the hypertension is severe and poorly controlled, the disease could progress faster. And similarly, if a patient has a IgA nephropathy with crescent, then again, the progression of the disease can be faster. Yeah. So in this patient, it was relatively rapid, and these might have been some of the risk factors for this.
Yes.
What is the basic defect in patients who have an IgA nephropathy?
Sir, there is a theory that these patients have galactose deficient IgA immunoglobulins, and IgG against these immunoglobulins are formed, which form immune complexes and deposit in the glomerulus capillary,
Yeah.
mesangium.
So defective galactosylation of the IgA1 molecule. Yes. So that is one of the major abnormalities that has been commonly found in these patients. I won't go into details of treatment of IgA nephropathy. I'm sure you would have attended. There have been recent sessions on IgA nephropathy, webinars by Dr. Edwin Fernando from Chennai, and Dr. Kher also, sorry, Dr. Jha also took a class on IgA nephropathy very recently on the management. So I won't go into details of that. And by and large, treatment has not really been very effective. Most treatments have failed to alter the course of the disease. I just, in passing, make mention of one treatment which has been recently tried. You've heard of any recent new kind of treatment that has been tried?
Sir, there is a trial on drugs sparsentan. Initially, a phase 2 duplex trial and a phase 3 duet trial was done on IgA nephropathy patients. And sir, April inhibitors, ataticept is a drug which is trying to be used.
Okay. Any new kind of steroid formulation?
So budesonide has been used. There are two trials, Nefigen and Nefigard. They are on the concept that local steroid release in the distal ileal region in the Peyer's patches might actually help reduce steroid toxicity and benefit patients from IgA nephropathy.
Yeah. So they've used budesonide. So this is called a targeted release formulation of budesonide, because the budesonide is released only in the terminal ileum. And but as yet, these trials are only preliminary, and no hard endpoints have been studied. And so as yet, the value of this drug also is not established. And the same applies to tonsillectomy for patients with IgA nephropathy. It has not really been very useful, so currently not recommended. So we leave the treatment of IgA nephropathy at this point and go on to the more recent problem which this patient is having. So as you said, he presented with some fever, with frothy urine and swelling.
Yes.
Yes. Okay. So can
sir,
you go ahead with his? Can you tell us more about this present illness?
Sir, actually, I have some history left on post-transplant course of this patient.
Yeah, go ahead with that. Go ahead.
Okay, sir, patient was on regular follow-up after transplant, and his regular TAC level and dose modification was done. 6 months into the transplant, patient had no complaint unless he developed a history of fever, pain abdomen, and multiple episodes of loose stool which lasted 3 to 4 days. Initially, he was being treated on OPD basis, but the symptoms increases and his creatinine started to rise from 1.12 to 1.17. So he was admitted. His blood workup was done, and he was found to have CMV infection. He was therefore given some injections and oral medications during this time, and later he was discharged with in normal state with a discharge creatinine of 1.2. On follow-up, within 15 to 20 days of therapy, on OPD follow-up, he was found to have hyperglycemia episodes, incidentally tested initially and managed with diet and lifestyle modification. But later on, since the sugar levels kept on increasing, he was kept on insulin support for the same. There was no history of any UTI or LRTI during this time, no history of any lower urinary tract symptoms. In the next 4 years, everything went well, and his creatinine remained in the range of 1.12 to 1.2 with insulin as therapy for hyperglycemia. 1 year back, he had history of fever and burning micturition. He came to the OPD and he was found to have raised creatinine from 1.2 to 1.8, and therefore he was admitted and given some injectable medications. The symptoms resolved. He was later discharged with a creatinine of 1.2 on immunosuppressive drugs. Since the past 1 year, he has been doing well. He has been compliant with his medication. There was normal blood pressure and sugar control and no history of any endogenous medication intake until 15 days back, when he started having fever with burning micturition and swelling over feet. Fever was one episode, high grade, non-documented, 15 days back, associated with chills and episodes of burning micturition, and for which he took medications and it was relieved with medication. There was no history of cough, vomiting, loose stool, or pain abdomen during this time. There was also history of swelling over feet, which increased from initially from the ankles to the calf, so much so that he had problems in wearing footwears. This was also associated with frothy urine, but there was no history of hematuria, graveluria, abdominal distension, or decreased urine output. There was no history of breathlessness or orthopnea. He was later evaluated. He came to the hospital. He was told he has some pus cells and RBCs in the urine. The creatinine rose from 1.12 to 1.5 and later to 1.9, and he therefore was admitted, and a kidney biopsy was done. TAC level done during this time showed a TAC level of 2.89 nanogram per ml.
Okay.
All right. So this was my history of present illness.
Yeah, just one brief point. The CMV was thought to be responsible for the loose motions, the episodes of loose motions that this patient had.
Yes, sir.
Right, and he received treatment for that.
Yes, sir.
Okay, and that occurred how much time after the transplant?
So 6 months.
6 months. Okay. Right. And when did the blood sugar levels go up after the transplant?
Sir, this was about a month or two after CMV infection.
After, so maybe 8-9 months.
Yes.
Okay, right. Go ahead. Yes.
So past history, there is history of surgery in his right forearm due to since he had a fracture due to a road traffic accident around 10 years back, for which he was operated. There was history of occasional NSAID intake during this period. There was no history of any surgery. Apart from this, no history of any childhood surgery or any history suggesting nephrotic syndrome in the childhood. Personal history: patient is vegetarian by diet. He has no addictions. Normal bladder bowel habits. Sleep, appetite was normal. Family history: there is no history of diabetes, hypertension in the family. No history of any renal disease in the family. So, That is all about history in my history.
Okay. So, any comment regarding the TAC level you said was only 2.89?
Yes, sir. Yes, sir.
When he presented this time.
Yes, sir.
So, any comment on this level?
Sir, previously it was done around an year back, and he was on the same dose. He does not remember the last dose. This time when we admitted him, he had this level.
Yeah. So we don't know about previous levels of serum create of tacrolimus.
Sir, he does not remember, but he told that 1 year back it was done, and he showed to the doctor, and he was told that this is okay, and there has been no change in medication after that.
No change in doses. So, okay. But what is your comment on this level?
Sir,
would you be
after 6
satisfied
months
with this level or not?
No, sir. Sir, 6 months after transplant, generally we keep a level of 5 to 6 nanogram per ml.
Yes.
And sir, since this was a transplant with high risk, high sensitization, we might consider a higher level of 6 to 7 maybe, or up to 8, depending on patient and clinical observation.
Okay. Okay, we'll come back to that. Yes. So what the point I'm making is that I would never allow a patient to have such low levels of tacrolimus knowingly. All right. I think the minimum level that I would consider safe would be something like 5 or 6 at the lowest. In fact, I prefer a level of 6 or more. That's my feeling, that that's where one should maintain the TAC levels, even if like this patient is 5 years post transplant. Even at this stage, I would maintain levels of more than 6 nanograms per ml. I am aware of many physicians, and in particular many transplant surgeons, who tend to maintain much lower levels than this, levels of something like 3 to 4. And they feel that those are reasonable. At least I would totally disagree with them, irrespective of the risk category of the patient. And I would not allow a patient to maintain such low tacrolimus levels. So I think that's an important point that I want to make. And I'll come back later to why we like to maintain higher levels than this. Right?
Sir, I had a question on this.
Yes.
So suppose the same patient 7-8 years into transplant, completely asymptomatic, comes on OPD follow-up. His TAC level is 8. So would you consider lowering the dose?
But see, in the range of, if it is in the range of 6 to 8, generally I would not reduce the dose unless the creatinine is elevated and I have a suspicion of TAC toxicity, acute tacrolimus nephrotoxicity. So I would not consider reducing the dose. And one other reason for that is we often see variability of the tacrolimus blood levels. Right? At one visit, the level may be 8. At the next visit, it might be 6.5.
Yes.
This, I'm sure you would have often seen that. So it's not that levels remain so tightly at a fixed value. They keep varying, even without any variations in the dose. You may have kept the patient on the same dose. The next time he may come with a value of only 6. So I would consider reducing the dose only if the creatinine has risen. Yeah. In that case,
one
yes.
more.
Yes.
So one more corollary, suppose same case, the TAC level on OPD basis is 3. Patient is completely asymptomatic, stable creatinine. Would you then
Yes.
consider raising the TAC dose?
Yes, I would, because that is what I've just stated, that I would not allow the creatinine to remain as low as this. It often happens that, a patient has been on follow-up with somebody else, and then he comes to me. And if he comes to me with a TAC level which is around 3, and say his previous reports are also around 3, I would definitely say that for me, this is not an adequate dose. Even if you've been doing well till now, I don't feel comfortable, because in the long term, at that particular time, it may be all right. The creatinine may be normal. But in the long term, you're always taking a risk of graft dysfunction developing. Yeah. And we'll be discussing graft dysfunction in a short while. So I would definitely increase the dose in that situation also, even if the creatinine is normal.
Thank you.
Now, okay. Now, a few very important basic questions that I'd like to ask you. When you do a transplant, what are your aims? What are you trying to achieve?
Sir, in the recipient, sir, renal replacement therapy, it has been seen that kidney transplants have better outcome in mortality and lifestyle as compared to other forms of renal replacement therapy.
Yeah, so you're talking about a comparison with maintenance dialysis, that you get better quality of life.
Yes, sir.
Right. So there's no doubt that a transplant is the option number 1 for a patient with CKD5. Dialysis would be a second option, not the first option. That part is okay. But when you do a kidney transplant, what do you want out of that? And what does the patient want?
Sir, better quality of life.
That you already mentioned, that he will get in all probability. If the graft functions well, he'll get good quality of life. But is that enough? Yeah, somebody's written it on the screen, long graft survival. Don't you want a...
Yes, sir.
You want that kidney, that allograft, to function for many years, isn't it?
Right, sir.
And
yes,
what
sir.
would, how many years?
Sir, it has been found that up to 50% patients do well up to 10 years after transplant.
So,
and
right,
average,
you're right. So, is that a good outcome? Would you be satisfied if you were a transplant recipient, 50% chances that that kidney will function 10 years?
Maybe not, sir.
No. Again, somebody has written on the screen 20 to 30 years. What I would say, I would not even limit it to 20 to 30 years. I would say that in whichever patient you do a transplant, you want that for the rest of his life, he should not require a second transplant.
Right.
Right? That would be the ideal. But as you already said, do we achieve that?
No.
Certainly not. We don't. Isn't that so? Although the longest survival that I have seen at least 2 patients who survived 34 years after a transplant. But then those are the exceptions. The majority, as you said, have a survival of 10, 12 years, 15 years at best. Right? So when we transplant them, we do not really give them the ideal graft survival that we want and that they want also. Number one. So remember this, your aim is that they should never require a transplant again in their lifetime, which we don't achieve, right? What's the second aim? The second aim is, yes.
So infection-free life survival.
That again is quality of life. Something else that's more important is, yes, somebody has again put it on the screen, prevent mortality. How long do you want that patient to live? Now we are not talking of graft survival. We are talking of lifespan of the patient. So you want to give him a lifespan that is equal to that of a age-matched individual who has not had a transplant.
Yes.
Right? So this patient is now 42. He's had a transplant at the age of 37. So you want to give him a life expectancy of something like 70 to 80 years, isn't it?
Yes, sir.
Okay, so that is the other aim of doing a transplant. Okay, remember these two are the most important aims. And now, so do we achieve that aim or not?
No, sir.
Unfortunately not. We don't. Right? So you do not get a good long lifespan in these patients. In fact, 50% of them will die with a failed graft. There'll be others who will die with a functioning graft. Isn't it?
Yes, sir.
So therefore, so none of these two aims that we have are we able to achieve. Right? So remember this is a very important basic fact of life as far as transplant is concerned. Okay. How do you categorize patients, the recipients rather, according to their immunologic risk? You mentioned that this patient was a higher risk patient. So on what basis do you categorize these patients?
Sir, this has been categorized on the basis of calculated PRA, and
Okay.
sir, it is a calculated PRA of more than 80% shows that the patient is high risk for kidney transplant.
PRA.
Yes, sir.
What do you mean by PRA?
Sir, it is a calculated PRA. Suppose, sir, the recipients.
What does PRA stand for?
Sir, panel reactive antigen.
Panel, you're talking about panel reactive antibodies.
Yes.
Okay.
Yes.
But anything else you take into consideration?
Sir, then like in living transplants, we do a CDC cross match, a flow cross match, and the results high CDC cross match positive or high mean channel shift in flow cross match shows high risk transplant rather than.
Yeah, so it shows a sensitized recipient you're talking about. But
Yes.
But is that all? Is there something else?
Sir, there is also a single antigen bead Luminix assay.
Okay, that will tell you a little more about sensitization.
Yes, donor specific antibody.
Yeah, a more sensitive test to tell you about that. Anything else? See, you can categorize live donor recipients, live donor recipients into 3 categories based on their risk level. You have those with the lowest risk, right? Those who are undergoing a first transplant this is very important. Is it the first transplant or is it a retransplant? So those with lowest risk or intermediate risk are those who are undergoing a first transplant. The lowest risk category accounts for only 5% of recipients, those who are getting a transplant from an HLA identical sibling. Right? So that will account for only about 5% of all recipients. The largest group is the ones which are in the intermediate risk category. These are those who are undergoing the first transplant. It's a live donor transplant. There is no sensitization, but the donor is either a 0 match or a 50% match. Like it may be one of the parents, it may be a spouse donor, right? It may be an unrelated donor, therefore. There's no sensitization, there is no ABO incompatibility, and this is the first transplant. Okay, this is the intermediate risk category. And what is the high risk category? Those who are undergoing a second transplant, or those who are undergoing a ABO incompatible transplant, those who are sensitized, as you had already said. And those who are undergoing a second transplant, the risk increases in those who have lost the first transplant due to rejection. Yeah. So not all patients who are having a second transplant are high-risk candidates. If the first transplant survived many years and was not lost due to rejection, and the patient is not sensitized, then he may not be a high-risk recipient. Right? So this is how you classify patients into risk categories. I hope you got it clear.
Yes, sir. Yes, sir.
Right. Okay. Now, let's talk a little bit about the donor spectrum in case of live-related donors. Right. In a live-related donor program, if you take 100 recipients, what would you think? What would be the breakup of the live-related donors? In India, I'm talking about the Indian situation.
So you're talking about the relationship?
Yes, exactly.
Okay. Sir, in India, sir, spousal donor is around 30 to 40%. Right. And rest are, sir, parents, mostly parents, and around 10% children.
Children or siblings?
Siblings, yes.
Yes. Children are the least common.
Least, yes, sir.
Yeah, because generally parents want to avoid taking a kidney from their children. So they are the least common group. The most common group, you are right, when you said spouses, and mostly it is wives.
Wife giving to husband.
Giving to husband, although it can also be the reverse way. But kidney disease is more common in males than in females. So it's more often wives to husbands, right? So I brought up this issue because, at the PGI Chandigarh, there was a time when we, in order to encourage live-related transplantation, we would refuse spousal donors. This was many years ago. So spousal donors at that time constituted only about 10% of all our donors, and parents constituted about 45%. But over the years, as the results of spousal donors have also improved, in fact, the results are almost as good as when you use a parental donor. So therefore, the usage of spouse donors has increased, and now it is something like 35 to 40%. Right? There are several reasons for this increase. There are other reasons also. One is that the joint family system in India has gradually broken down. We have mostly nuclear families, right? So that's why the only donor that is available is a spousal donor. And then the older the recipient, the less chances that he's going to be able to find a parental donor, because the parents will be too old to donate a kidney. So supposing you have a 50-year-old recipient or even a 45-year-old recipient, it's very unlikely that you'll find a parent in a suitable age group which can be accepted. So you'll have to accept a spouse donor. So, so spouses are number one, parents are number two, siblings are number three, offspring are number four, and then you also have other categories of unrelated donors, like for instance mother-in-laws, father-in-laws, and so on, and a little more distant relatives, right? So that is roughly the breakup of donors. And so far, cadaver donors in India account for only about 5% of all transplants. Okay. Okay. Now coming to the immunosuppression that we use. So, what kind of induction immunosuppression can you use?
So there are two types of induction agents. There can be depleting and non-depleting agents.
Yes.
So in the non-depleting agents, there is IL-2 antagonist like basiliximab, and in depleting agents, there is alemtuzumab, CD52 antagonist, and ATG, anti-thymocyte globulin.
Okay. So which of these are monoclonals? Which of these is a polyclonal agent?
So basiliximab is monoclonal, and alemtuzumab is also monoclonal, and ATG is polyclonal, and grapholon, Fresenius ATG, that is.
Yeah, these are polyclonal. Yes. So you have three induction agents. Alemtuzumab is only theoretical for us. It's not available in India. So it's virtually two agents only in India. And in your patient, this received ATG.
Yes.
Yes. So generally, how many doses of ATG are given?
Sir, the dose recommendation is 3 to 6 mg per kg, depending on patient status. In our center, we give 1 mg per kg for 3 consecutive days after transplant.
Okay, so it comes out to 3 mg per kg then.
3 mg. And the first dose is given before release of clamp of the donor kidney.
Okay, so you give it on day 0.
Day 0 before the patient goes to the OT, we start the dose.
Okay, there could be difference in the regimens that from unit to unit. Like for instance, we give the first dose on day -1, 1 day before, because the infusion is given slowly, so you need some time to give it. So generally we give it 1 day before, and the second dose on generally we can give it on day 0 after the transplant, but we most of the time we prefer to give it on day 1, because on day 0 a lot of things are going on. The patient has just come back from the theater, you're watching the urine output, you're worried about electrolytes, you're worried about the fluid replacement and so on. So we prefer not to give ATG on that day, lest it cause any complication, and we give it the next day on day 1 generally. So day -1 and day 1. That is the schedule that we are following, and we generally give 1.5 milligram per kilogram. So the total comes to again 3 milligrams per kilogram. So this is a low dose regimen of ATG that most units in India are currently using, right? So now we've already just talked about the immunologic risk categories. So this is the agent that you would prefer to use in the higher risk category.
High risk category.
Yeah. In the intermediate risk category, you can use either basiliximab or you can do without induction. And in the lowest risk, you can do without an induction agent. Right. So that is generally what I would do as far as induction therapy is concerned. Now, since when has tacrolimus been in use in kidney transplants?
Sir, in India or in
India,
world?
for instance, yes.
Sir, in India, in early 2000, it has been in use since early 2000.
Yeah, and even if you go abroad, it would have been about 25 years or so. So it started in the mid 90s or so, early 90s. Yes. Yeah. And in India, it came in around 2000 or so. And so I just want to emphasize this point here, that for the last 25 years, we've not really had a new agent which could come and replace tacrolimus. That's the important conclusion that I'm drawing from this. That in many fields, we have so many new drugs, so many monoclonals, so many anti-cancer drugs, and so on. But in the field of renal transplantation, even after 25 years, we don't have a replacement for tacrolimus. Okay, so what dose would you start with? What level would you maintain in the first week? Coming back to the levels once again.
Sir, generally we start with the dose of 0.1 mg per kg, and we target a level in the range of 12 to 14 nanogram per deciliter in the first 2 to 4 weeks. Depending on the status, suppose it's a low risk, we can even target something around 10 to 12.
Yes,
but ideally 12 to 14.
Yeah. So so something like that. I would agree with those figures. So in most patients, we target something like 10 to 12 in the first week or so, first few weeks, and then gradually come down to lower levels of 8 to 10, and then around 6 to 8. And as I said earlier, 6 to 8 is our maintenance, long-term maintenance level that we would like to maintain. And yes, the starting dose, as I said, I generally calculate a minimum 0.1 milligram per kilogram, maximum 0.14 milligram per kilogram. Right? So that's what I would take as the starting dose, because you don't know what level will turn up in the patient. You will only know after you have done the testing. And what advice do you give to the patient regarding the dose? How does the patient take it?
Sir, generally taken 2 hours before meals.
Taken before meals, yes. 2 hours is not necessary. It should be taken while the patient is fasting. That is to ensure the best absorption, because food interferes with its absorption. So even half to 1 hour may be enough. The gap of half to 1 hour before meals may be enough. So the same thing in the evening, half to 1 hour before dinner and half to 1 hour before breakfast. and the patient should stick to this pattern even later on. So he should not keep changing the schedule, that sometimes he takes it after meals, sometimes he takes it fasting, because that can then influence the blood levels that you are achieving. You will get variability in the blood levels. If you want to reduce the cost of a CNI, how would you do it?
Sir, CNI is metabolized by cytochrome enzymes. So if we combine CNIs with cytochrome inhibitors, so it has been seen like Bilzim, calcium channel blockers. So
Yes.
it has been seen that we can use lower doses and still attain levels.
Okay. Any other drug besides Dilzim?
Sir, fluconazole has also been seen to be used in some patients.
It's ketoconazole, not fluconazole.
Sorry, yes.
Ketoconazole. Yeah, you use ketoconazole 100 milligrams or diltiazem 90 milligrams. And with which of these do you get a greater effect? Not sure. It's ketoconazole. With ketoconazole, you can have reduce the TAC dose by as much as 50% or even more, whereas with diltiazem you get only a 25% reduction in the dose of tacrolimus. But these nowadays, with the fact that the price of tacrolimus has also come down as compared to what it was a few years ago, so these are not being used very often nowadays. Okay. Between what side effects does cyclosporin have, which you do not get with tacrolimus?
Sir, cyclosporin has had this problem of coarsening of facial features and facial hair and increased hair growth.
Yeah, hypertrichosis.
Yes, sir.
Yeah, so that's a cosmetic side effect, particularly for female patients. It would be disturbing. Any other?
So gingival hyperplasia.
Yeah, gingival hyperplasia has come up on the screen. So that's an important side effect. Yes. You know of any other commonly used drug, not related to transplant, but a drug that we nephrologists commonly use, which can also cause gingival hyperplasia?
So phenytoin.
Yeah, anticonvulsants, but anticonvulsants not something that we use. And any other drug? It's on the board again. It's amlodipine. Yeah. Amlodipine is, or any calcium channel blocker, in fact. More frequent with nifedipine, but also with amlodipine. Okay. So yes, so we had gone on to cyclosporin. And in contrast to cyclosporin, what effect does tacrolimus have on hair growth?
Sir, it causes alopecia.
Yeah, it's the opposite. So it can contribute, doesn't always cause that, but can contribute to alopecia. Yes. Okay. Next we come to, yeah, so you give tacrolimus, and what else do you combine it with?
Sir, immunosuppressive agent.
Yes,
mycophenolate.
Right.
Mycophenolate sodium.
Right. Now, what is the mode of action of mycophenolate?
Sir, it is an anti-proliferative agent. It inhibits purine synthesis.
Yeah. Do you know the name of the enzyme which it inhibits?
Sir, IMP phosphate.
IMPDH, that is inosine monophosphate
Dehydrogenase.
dehydrogenase, right? Yeah, so it's an inhibitor. And what is the active compound in MMF?
Sir, mycophenolic acid.
Yeah, right. Mycophenolic acid. Although you have mycophenolate mofetil and you have mycophenolate sodium. These are the two compounds that we use, but it's the mycophenolic acid which is the active metabolite, right? And what is the dose that you usually start with?
Sir, we start with a dose of 720 mg of mycophenolate sodium in morning, evening.
Yeah, or 1 gram of mofetil.
Mofetil, yes.
Right. And yeah, one other small point, there may be variability on this also. I generally prefer to start TAC and MMF about 48 hours before the transplant. But there are many units which will start these drugs only on the evening before the transplant. Yes. That is day -1 evening. Right. So again, there is a difference of opinion on this. So no hard and fast rule. Okay. And what happens to the dose of mycophenolate as time after transplantation increases? Does it change?
Sir, we generally reduce it after maybe 6 months of transplant. From 720 BD to we come down to 360 BD.
360 BD would be a little too drastic. I would come down to 540 BD at 3 months. Or if you're using mofetil, then come down to 750 BD at 3 months from 1 gram. That's what I would prefer. What is the most disturbing side effect of mycophenolate?
Sir, there are two common complications. One is bone marrow suppression. The other is gastroenteritis.
Yeah, so the diarrhea. Yes, bone marrow suppression, of course. So cytopenias and diarrhea. Now, if you have diarrhea due to in a patient on mycophenolate, what happens to tacrolimus blood levels?
Sir, the MDR channels, they get damaged and there is increased absorption of tacrolimus in these patients. So that there is a risk of tac toxicity in these patients.
Yeah, so there's an effect on the P glycoprotein, which is responsible for the absorption of tacrolimus. So you get more absorption of tacrolimus. So the creatinine can go up as a result of TAC nephrotoxicity. So remember that when any patient on TAC and MMF gets diarrhea and the creatinine goes up, this is what you should suspect. This is the reason that you should think of if dehydration is not an important factor, right? And as the diarrhea subsides and the TAC levels come down, the creatinine will also gradually come down. You may need to reduce TAC doses for a short period of time at that time. What is the third immunosuppressive drug that you give to these patients?
So steroids.
Steroids. And you start with how much?
Sir, in our hospital, we give a pulse of 500 mg on day 0 before the patient is shifted for surgery. Then yes. The next day we come to 250, then 125, and we gradually taper it down and we discharge on around 30, 35, and 25, 30 mg, depending on baseline status.
Right, right. So the oral dose of steroid is about 25 milligrams of prednisolone at the time of discharge. And generally, yes, we would come down to around 5 milligrams by the end of 3 months, provided there is no problem. Okay, so this is the standard protocol that virtually all centers are using currently for both induction and maintenance. Is there are there any other drugs which you can consider for use?
Sir, we have used Sirolimus and Everolimus, which are mTOR inhibitors. They have been used in transplant cases as well.
Yes, but what is their current status?
Sir, there have been few trials like Convert trial and Transform trial, which have shown some benefits, but overall, there are some problems with these drugs. One is there is poor surgical site healing. Then there is problems with proteinuria, and there have been reports of increased rejection in these patients. So they are not very commonly used. But if there is problem with maintaining TAC levels in patients or who have post-transplant TMA with a suspicion of tacrolimus causing TMA, then they have been used.
Yeah. So, but they are considered suitable for use only in those patients who have a relatively low risk of rejection, not in the high risk group, right? Because as you said, there is a higher rejection rate, so therefore they are not suitable for high risk categories of patients. And in the Transform trial, how have they been used?
In the Transform trial, sir, they were used as low dose tacrolimus, sirolimus, and other drugs simultaneously
Yeah,
versus
low
MTA
dose
group.
sirolimus or everolimus, low dose tacrolimus, and steroid.
Steroids.
Yeah, so that was the combination. So if at all you want to use one of the mTOR inhibitors, then this is how you would use it currently. But very few units are using mTOR inhibitors at the present moment. Any other side effect that you may sometimes get with an mTOR inhibitor?
There are common side effects are oral ulceration, dyslipidemia, proteinuria, poor graft site,
Wound
and
healing.
sir, there have wound healing.
Yeah. I had a very interesting experience. We had a patient with a malignancy post-transplant, and because of that, we put him on sirolimus.
Yes.
We switched him from tacrolimus to sirolimus because of the malignancy. And he developed, yes, somebody has put it there, interstitial pneumonia.
Interstitial pneumonia, yes, sir.
Yes.
This is also reported.
So you can get a bilateral lower lobe, predominantly lower lobe pneumonia. This is a diagnosis of exclusion. Because differentiating from a bacterial pneumonia is very difficult. And generally you have to stop the drug if that kind of thing happens. So we've had that kind of experience. And so then we had to. So, but one situation where you may consider giving a patient an mTOR inhibitor in place of a CNI is a patient who has had a malignancy. And this has been done particularly in patients who have had PTLD sometimes, or in patients who have had a Kaposi's sarcoma, or in those who have had squamous cell carcinomas of the skin. Because then this drug is thought to reduce the risk of recurrence of the malignancy. Any other substitutes for mycophenolate?
Azathioprine, sir.
Yeah, azathioprine. I don't think you should forget azathioprine. We have, because we belong to the pre-MMF era, so we have used a lot of azathioprine. And I think it was a very good drug. It still is a very good drug. You know, there is, I think, the claim that MMF is superior to azathioprine is more a drug company generated opinion rather than the complete truth. So as I think azathioprine is still a very good drug, and one of the most important situations, common situations where I have used it in place of to replace MMF in patients who have severe GI symptoms.
GI symptoms.
I don't hesitate to take off MMF and replace it with azathioprine, because I have seen that in something like 5 to 10% of patients on MMF, the GI symptoms can be so severe and resistant to any form of therapy and recurrent that the only solution is to stop MMF and put them on azathioprine. And I don't hesitate to do that. I have even seen patients who have lost their appetite, lost weight as a result of persisting with
GI
MMF.
symptoms.
So I would not hesitate to do that. Right? There is one very important drug interaction that you should remember in case of azathioprine. And what is that?
Sir, in patients with TMPT mutation, use of azathioprine with xanthine oxidase inhibitors can cause drug toxicity.
What toxicity occurs?
Sir, there can be bone marrow suppression.
Yes, because when you are using a xanthine oxidase inhibitor like allopurinol or febuxostat, the metabolism of azathioprine is interfered with. So you get an enhanced effect of azathioprine, which means bone marrow suppression. So this is a very important interaction to remember. So if a transplant recipient who is on azathioprine develops gout and you consider giving him allopurinol, always remember this interaction, right? So you can, in that case, give him mycophenolate mofetil. There'll be no interaction, but you can't give azathioprine. Any other modification of this triple drug regimen that you just told us about?
Sir, mTOR and
Oh, we have
drug
already
regime.
talked about that. Anything else? What about steroid-free regimens?
Steroid sparing regimes? Yes, sir. There have been trials which have shown that we can also, in low risk transplant, we can also do without steroids. Initially, we give it for 4 to 7 days, and then we can abruptly stop and maintain patients on 2 drugs rather than 3 drugs.
Yeah, the 2 drugs will be TAC and MMF. And usually you use an induction agent in these patients.
Yes, sir.
Yeah, so induction is used in all these situations along with TAC MMF. And as you said, you withdraw steroids abruptly at 7 days. So you don't use steroids for a longer period of time, right? So these are steroid-free regimens.
For children. Yes.
And there are many studies which have shown that as many as 3/4 of patients can be maintained without steroids. In 1/4 of them, you may be forced to restart steroids because of the occurrence of rejection. But in the vast majority, you can manage these patients without steroids. Right. So that's one option. Any other drug which is a substitute for the calcineurin inhibitors?
Sir, belatacept is now coming up as the new drug.
Belatacept, okay. Yes. So, and so how do you use belatacept, or what do you combine it with?
Sir, it is a co-stimulatory blocker. It is generally used in, it is an injectable drug. So generally used in children who have, where we have problems with compliance, or patients who have had thrombotic microangiopathy due to CNI. So we can use belatacept in these cases.
Yeah, so belatacept in combination with mycophenolate mofetil and steroid. Right. So it's a replacement for the CNI.
CNI.
What is the disadvantage of belatacept?
Sir, we have to do an EBV status of the patient. It cannot be used in EBV negative cases. There is very high risk of PTLD in these patients.
Yeah, there is a higher risk of PTLD. That's one. But any other inconvenience of using belatacept?
Sir, it is an injectable drug.
Yeah, it's an infusion. An infusion each time. So in the early stages, it is more frequent. Later on, it's a monthly infusion.
Monthly infusion, yes.
So that's an inconvenience. So there can be compliance problems. Patient has to come back to the hospital to take the infusion. So again, belatacept is being used very little as yet. And
available in India?
No. Not as far as I know. I have no experience of using this drug at all. I don't think it's available in India. And has not proved to be a big advantage over the regimen that we are using. So therefore, has not really replaced Tacrolimus in the vast majority. What else do you add to the prescription of these patients once you discharge the patient from hospital?
Sir, we give CMV prophylaxis.
Okay.
Sir, pneumocystis carinii prophylaxis.
Yes.
And antifungals.
You give antifungals to every patient?
Sir, we give clotrimol oral cleaning agents, not oral.
Oh, that's okay. Yes. That's okay. Yeah, yes. Not any
oral,
systemic antifungal.
No, sir.
No, yeah. Okay. So cotrimoxazole is standard prophylaxis, which you give for at least 6 months. That is standard prophylaxis for pneumocystis infection. It incidentally also protects against UTIs and toxo and nocardia and so on. Yes, but it's mainly for pneumocystis carin or zero vacci infection that you're giving it. I'm aware that most units where ATG is being used will be giving valganciclovir prophylaxis for CMV. I personally don't use it because I feel the risk of CMV even after low dose ATG is insignificant, and this adds to the cost of therapy. So I personally don't use it, but I'm aware that this is one of the agents that most units are prescribing, and they're giving it for about 6 months again, 3 to 6 months, right? Any
sir, one question.
Yes.
Sir, yes. If you're not giving valganciclovir, do you add acyclovir to the
no, we are not giving anything to our recipients.
And sir, for how much long are you using cotrimoxazole?
6 months.
Duration 6 months.
Yeah, 6 months. Yes, we are not using it after that. Is there any situation in which if a transplant recipient comes to you, it would be necessary for you to switch from MMF to azathioprine.
Sir, as you mentioned, intractable diarrheas.
Yeah, that is covered. Anything else other than that?
Pregnancy.
Yes, somebody put it on the screen. So pregnancy is an indication for switching to azathioprine, because drugs like MMF, mTOR inhibitors cannot be used during pregnancy. You can use calcineurin inhibitors, you can use steroids, and you can use azathioprine. Okay, so remember pregnancy. Okay, so we've spent a lot of time discussing these basic questions regarding transplant. Now coming back to your patient.
Yes.
So yes, can you tell us the biopsy report? I don't think you told us the biopsy report of the transplant.
No, sir, I did not.
Yeah.
Sir, in the transplant kidney biopsy, there were 9 glomeruli, one of which was sclerosed. There was peritubular capillaritis. C4D was negative, and one glomerulus showed segmental sclerosis. There was features of ATN, and IFTA was 20%.
Glomeruli?
Sir, 9 glomeruli, one sclerosed, presence of glomerulitis, peritubular capillaritis, C4D negative, and 20% IFTA.
Yeah. What about
IF?
Yeah, immunofluorescence?
Yeah. Yes, sir. DIF was done. IgA was 3+, C3 was 1+, and kappa lambda was equal, 2+ each.
So IgA 3+ in the glomeruli.
Yes, sir.
I presume it would have been mesangial mainly.
Yes, sir. Yes, sir.
But light microscopy wise, the glomeruli were largely normal then? Because you mentioned only one sclerosed glomerulus out of 9.
Yes, sir. Out of 9, 1 was sclerosed, 8 were looking good.
Normal. Okay. Yes. How much proteinuria did this patient have, and what was the creatinine?
Sir, we did a PC ratio. It was 3.02.
Okay.
And creatinine, it raised from 1.12 to 1.8. Over
maximum 1.8.
Yes, yes, sir.
Okay. So now we'll come to the question of graft dysfunction, right? This is what this patient has presented with, right?
Yes.
Now, in what ways does graft dysfunction present?
Sir, it can present as increase in creatinine or increase in proteinuria.
Yeah. So these are the two ways in which, in fact, in this patient, you have both things.
Both.
You have proteinuria and you have a rise in creatinine levels. So in some patients, you may have only proteinuria, or you may have only a rise in creatinine levels. And the third thing is in this patient, as you have both the things. All right. So that's how graft dysfunction in a transplant recipient presents. And graft dysfunction can be early or can be late. Right?
Yes.
And it's important to differentiate between early and late, because then the causes the differential diagnosis becomes different. All right. Now, in this patient, this is 5 years post-transplant.
Yes, sir.
Okay. So now you have to consider causes that would cause graft dysfunction 5 years beyond transplantation. Those which would have caused it earlier in the course of transplant are all ruled out.
Ruled out. Yes, sir.
become very unlikely. So which ones are the ones which are much more likely to occur in the early post-transplant period, say the first 6 months to 1 year?
Sir, in the initial 6 months to 1 year, sir, acute infections and acute rejections can be causes which can cause, and in the initial part, surgical causes are the ones which can cause graft dysfunction.
Okay, we leave out the surgical causes. We won't cover those. So yes, acute rejection is one important cause of graft dysfunction in the early post-transplant period, right? What
Yes,
else did you say? Infection.
infections, yes, sir.
Okay, yeah, sometimes a severe infection. Are you talking of infection of the urinary tract or infection elsewhere?
Sir, mostly urinary tract, but like CMV infections or other infection.
Okay, can sometimes, yes. Okay. Anything else which can affect graft function early?
Uh,
You must never forget BKV.
BKV, yes, sir.
Yeah,
Yes, sir. Yes, sir. Yes, sir.
BKV is very important because unless you, that is something which you, if you don't look for it, you're going to miss it until it is too late, right?
Right, sir.
And then you won't be able to reverse it. It will irreversibly damage the graft. So therefore, BKV is something that very important. And how does BKV present?
Sir, BKV, initially there is Urea and viremia, and later on it can present as asymptomatic rise in creatinine, as a creeping creatinine, and it can also cause bladder hemorrhage and ureteral stenosis.
Yeah. So does it cause proteinuria?
Yes, sir.
Does it? Where is the pathology in the kidney?
Sir, in the it is in the medulla corticomedullary region, interstitium,
No, is it in the glomeruli or the tubules?
the tubules.
So if it is in the tubules, why should there be proteinuria?
No. Yes, sir.
So it does not present with proteinuria. It presents only with an asymptomatic rise in the serum creatinine levels, right? Which is very gradual in the initial period. And you need to be able to diagnose this condition even before that rise in serum creatinine occurs.
Yeah.
So how will you diagnose it? If you want to diagnose it so early, how do you diagnose it?
Sir, ideally we should do a urine BKV levels, but it is not available. So we do a screening of serum BKV levels.
Yeah, urine can also be done. It is available, but serum is more reliable than urine.
Urine.
Right? Short of a biopsy, it's the BKV PCR on the blood, which is the best test. So therefore, you've got to do active surveillance of these patients right from early post-transplant. Right? So although this test costs money, right? So in the first 6 months, do it preferably every month or at least every 2 months so that you diagnose it very early. Because the only way to save these grafts, there is no drug which will target this virus. So far, we have no drug which can destroy this virus. So the only thing that can reverse this process is lowering the intensity of immunosuppression at this stage, right? Very early, before the serum creatinine rises. And generally what is done is that you can reduce the MMF dose by 50%, or some people would even take it off completely. And you can also reduce the TAC dose by 50%.
Yes,
some people believe in switching from TAC to cyclosporin. Yeah. So because most of these cases of BKV nephropathy were described in the Tacrolimus era.
Tacrolimus, yes.
Right. So Tacrolimus may have something to do with it also, with the increased risk. Of course, when you make all these alterations in the regimen, there is some increased risk of rejection also, but then you have to take that risk and go ahead, right? And if you find the blood BKV shows that the cutoff, that the level is more than the cutoff, which is diagnostic, then you can go for a graft biopsy also, which is the gold standard. And what would you find on the biopsy?
Sir, there are features. Sir, important thing is we have to take the medulla. When we do a biopsy suspecting BKV, we should, it is the particles, viral particles are mostly in the medulla. So we should have a sample of medulla, and there is staining of BKV along with features of interstitial inflammation.
How do you stain for BKV?
Sir, JC, we have a stain, polyoma virus stain, SV40.
SV40. SV stands for simian virus.
Simian.
Yeah, simian virus, large T antigen. So that's called SV40. So you stain for that. And so in which part of the cell do you find the positive staining?
Sir, in the tubules.
Yeah, as we said this earlier also, it's in the tubules, but it's in the nuclei.
Nuclei.
The nuclei, on light microscopy, the nuclei are enlarged. And the nuclei are also variable in size from one nucleus to another. Right? So enlarged nuclei, anisonucleosis, nuclei of variable size with intranuclear inclusions. And this is where the positive stain is found. Okay. So in a patient with early infection, if you have picked it up early, you will have only these inclusions. In a patient who is a little advanced, you will have interstitial inflammation as well. You may have tubulitis also. And in a patient with more advanced disease, you'll have IFTA.
IFTA.
Yeah. So you need to pick it up when the patient has only the intranuclear inclusions to get a good result. If you already have IFTA, probably the graft is already gone. So that I think covers most of BKV. The only point, one other point I'd like to emphasize about BKV, supposing you have lost a graft due to BKV and the patient says he wants another transplant, can you do it?
Yes, sir.
Yes.
Sir,
so how
initially
there was
a role of, it was believed that transplant kidney nephrectomy should be done, but now they say that there is no role of nephrectomy. We can do a BKV blood PCR levels, and once it is on the lower side, then we can go ahead with transplant.
So how will the PCR levels come down?
Sir, when the patient is off immunosuppression.
Yes. So when the graft has failed, you take off immunosuppression. He's on dialysis, right? And you wait till the BKV becomes negative, right? And then you can go ahead with a retransplant without an increased risk of recurrence. So it's only if you want to do a preemptive transplant in such a patient, you don't want to wait, then you can do an allograft nephrectomy and go for a preemptive transplant. That's the only situation in which you do a nephrectomy. Okay. Now, coming to the question of what your patient has, right? So your patient presented with proteinuria and a rising creatinine, and the biopsy showing significant IgA deposits in the glomeruli. You have also some IFTA, some acute tubular necrosis, some peritubular capillaritis, you said, but C4D negativity.
Yes.
Right. So what is your diagnosis on the basis of this biopsy?
Sir, I'll keep a possibility of a recurrence of primary disease.
Yes. Recurrence of primary disease. So recurrent IgA nephropathy, which is confirmed by the presence of 3+ IgA in the glomeruli. So there's really no doubt left as far as that is concerned. So now coming to the question of recurrent GN. So what are the GNs which recur in the allograft?
Sir, IgA nephropathy is a very common diagnosis. It recurs at a rate of around 50% over 5 to 10 years in transplant. Other diseases like C3 glomerulopathy have been found to have a very high recurrence of up to 80 to 90%. Then membranous nephropathy has been shown to recur. Lupus nephritis can recur. ANCA has also been shown to recur.
What about
FSGS?
You didn't mention FSGS.
FSGS, yes. Sorry. FSGS has a very high rate of recurrence, around 40 to 50% over 5 years, with a graft loss of 12% over 10 years.
Yeah, you clubbed lupus and ANCA vasculitis with all of these. I don't think you should club them together, because if you look at lupus, the recurrence rate average recurrence rate is only about 10%.
Yes, sir.
And even in ANCA vasculitis, recurrence rate is around 8.5%, mostly extrarenal recurrence. On a TAC-MMF regimen. So the recurrence rates with those conditions are not that much, not really that much. So the recurrence rates are higher, as you said. C3 glomerulopathy is, yes, one of the highest recurrence rates. C3 glomerulopathy and dense deposit disease both have high recurrence rates, right? The FSGS, as you mentioned, and IgA nephropathy and MGN would be slightly lower than that. And recurrence rates, obviously, they'll vary from studies to study depending on how many years the patient has been followed up. The longer the patient has been followed up, the greater will be the recurrence rate. It's a function of time, right? So these are conditions which do tend to recur relatively commonly. In case of FSGS, it's mentioned that the rate of recurrence is up to 30% after the first transplant But if the first transplant is lost due to recurrence, the recurrence in the second transplant may be as much as, recurrence rate may be as much as 70%. And one other important difference between recurrence rates in these various glomerular disorders, in which is the condition which tends to recur very early?
Sir, in glomerulonephritis or otherwise?
Glomerulonephritis.
Sir, FSGS has been shown to recur even on table after transplant.
Yes. So FSGS is the one that recurs the earliest following transplantation. That does not mean that graft loss will occur very early. What we are talking about is proteinuria. Proteinuria comes up very early. The creatinine may be absolutely normal at that time. And so even if you have a recurrence of proteinuria, say at 3 months or 6 months post-transplant in a patient with known FSGS, even if you do a biopsy, what would you find?
So there can be features of FSGS in the biopsy.
No, you won't find FSGS so early. You'll find only food process effacement. That's it. On electron microscopy. Yeah, somebody has put it up there. You won't find FSGS so early. The FSGS lesions on light microscopy will come up much later. Right? They may come up at 1 year, 2 years, much later.
Okay, sir.
So that's the important thing to remember. And that's one of the purposes of doing EM on a graft biopsy. So you look for food process effacement in that situation. And while we are on that, what other situations would you like to do an EM on the allograft biopsy?
Sir, if we are suspecting chronic antibody-mediated rejection,
yes,
then for transplant glomerulopathy, we need to do for stage 1A, we need to do an EM or capillary multi-layering of capillary basement membrane to be seen.
Yeah, so you're talking of two different situations. One is if you are looking at the glomerular capillaries in case of early transplant glomerulopathy, right? The earliest stage of transplant glomerulopathy can only be the duplication of the capillary basement membrane can only be identified by EM. More advanced stages you'll identify by LM. And finally, the multi-layering of the peritubular capillary basement membrane. You have more than 7 layers, right? For proving diagnosis. So that multi-layering you will find only on EM. Okay, so those are the things where you require EM in case of yes, coming back to FSGS, which type of FSGS does not recur in the transplanted kidney?
Sir, if it is a steroid resistant FSGS or a genetic type.
Yes. So the genetic type, if you are definite that a patient has a genetic variety of FSGS, you don't always screen for genetic abnormalities. But if you have patients with a family history or you've done a genetic screening and that is positive, then you can reassure the patient that your disease is not likely to come back after transplantation. Okay. Yes. What about any other glomerular diseases? What about recurrence rates in other than what you have already talked about?
Sir, oxalosis, if we have done only a kidney transplant in patients who has a primary disease as oxalosis, there is very high recurrence with graft loss in these patients.
Oxalosis, fine. But what about, I'm still at glomerular disease.
Okay. Sir, membrane, IgA and...
IgA you've talked about. IgA, MPGN, MGN, FSGS, ANCA, SLE, we have talked about these already. Any other glomerular disease?
Sir, Alport.
Alport, okay. Does Alport recur?
Sir, Alport can have a post-transplant. It can present as anti-GBM disease
Very
with a
rare,
rapid
yes.
graft loss.
Yes, but Alport doesn't recur.
No, sir. Alport won't recur.
Alport will not recur. You may rarely get anti-GBM disease in a Alport syndrome who has been transplanted. Okay. Does anti-GBM disease recur?
Sir, it can recur, but very rarely.
I would never mention a recurrence. It's virtually never. And anti-GBM does not relapse also. In contrast to ANCA-associated vasculitis, where you need maintenance therapy, you don't need maintenance therapy in anti-GBM disease. Okay, so it's only a one-time occurrence. It doesn't recur after transplant. So I would not even mention rarely.
Okay.
Right? What about secondary amyloid?
So secondary amyloid can recur, yes, sir.
Can recur, but again, not very common, about 10% recurrence rate. Right? If you have taken care of the condition that caused the secondary amyloid, then the recurrence rates should be low or negligible, right? So that covers. What about diabetic nephropathy?
Diabetes nephropathy. So diabetic nephropathy can also have recurrence, but it is said that at least 2 years it needs for recurrence to be obvious on a biopsy. And clinically, it can take more years because around 10 to 12 years is required for proteinuria to appear, microproteinuria, and 20 to 25 years for renal dysfunction. Generally, grafts do not last that long, so we have found it on protocol biopsies, but not in.
You may find. You may not find clinical evidence of recurrence, but you may find histological evidence of recurrence relatively early, say at anywhere from 3 to 4 years after transplantation. But you should mention this just to complete the list.
Yes, sir.
Right? Okay. What about you mentioned oxalosis? Yes, that's true. That oxalosis is one condition where you should not do only a kidney transplant, because there is a very high recurrence rate and almost invariable recurrence. So ideally, you need to do what?
Sir, a simultaneous liver kidney transplant.
Liver kidney transplant. Okay. You heard of any new drug for the prevention of damage in oxalosis, prevention of kidney damage?
So there are 2-3 drugs which were, one was LDH inhibitor, and there was 1 or 2 more drugs.
Somebody has put it up. Lumasiran.
Yes.
Read up all about it.
Yes.
I won't go into the details of that. This is a new drug which has come into the field, not available in India, but must read up about this. Okay. What? And any other diseases where it's very important to diagnose them pre-transplant. Otherwise, you'll end up with egg on your face. In other words, you get a very early recurrence.
Thrombotic microangiopathies, atypical HUS.
Yes, yes, that's very important, because in certain types of atypical HUS, there's a very high recurrence rate. And there again, you need to consider a liver kidney transplant, right? So, and anything else?
Sir, C3GN is also.
Yeah, we already talked about C3GN, dense deposit disease. Yeah. Anything else?
I cannot think of.
One hint, and you have an elderly patient with CKD.
Sir,
65-year-old.
MGRS or myeloma cases.
Myeloma, yes. Don't forget myeloma. So you should never miss a diagnosis of myeloma or yes, MGRS, which is less common. So a patient with a myeloma cast nephropathy or a myeloma associated amyloid, light chain amyloid, these are conditions which would again be contraindications to transplantation until you have effectively treated the underlying condition. Right? Otherwise, you'll have graft loss again, which can be fairly early. Okay. So that I think more or less covers the recurrent conditions. If there are any areas that I've left out, you can go into them on your own. I saw a recent patient, one question. I saw a patient a few days back only who came on to my follow-up 7 years after transplantation at Bombay. Prior to coming to me, he was on follow-up elsewhere, irregular follow-up. And when he came to me, there was a persistent microscopic hematuria. Okay. The creatinine was normal, no proteinuria. He was otherwise asymptomatic. But over the last 6 months, he had urine reports, all of them showing 20 to 25, 25 to 30 RBC. That's it.
Sir, what is the age of the patient? Age of the patient?
60.
60 years. Sir, we should look for cause of hematuria. One thing is we should check for dysmorphic RBCs, and at high risk it could be glomerular or non-glomerular. At this age group, non-glomerular hematuria would be more common, but depending on the primary disease, even IgA nephropathy with recurrence should be kept as a possibility.
Okay, you can keep, yes, you can keep IgA nephropathy, that's fine. That's one possibility. But I think urologic causes of hematuria become very important in this situation. Like malignancy, somebody suggested. Yes, a malignancy is important. It could be a carcinoma of the bladder, for that matter. But in this patient, it turned out to be something more benign, and you'll be surprised to hear about it. I asked him to get an ultrasound done as the first investigation. And he came back with an ultrasound report showing a forgotten stent. The stent that had been put in at the time of transplantation had never been removed. So sometimes you can be surprised, you can get cases like that also. Right. So, in fact, a stent that has stayed inside for such a long time is not easy to remove, because with it becomes adherent to the surrounding structures, to the bladder wall. It develops crusts of crystals inside it and around it. And so it can even break while you're trying to remove it. So in fact, so we had to take the help of a urologist to remove it. And what he did was he put in a guide wire into the stent from the end in the bladder right up to the end in the kidney. So what the guide wire does is that it straightens out the J curve at both ends.
Yes, sir.
Right? And it also, if you're able to get it through to the other end, it prevents a broken, if the stent breaks during removal, it prevents the broken piece being left behind. Right? So that's the trick, how you remove such a forgotten stent. In a transplant recipient, what is in the standard prescription, what is the commonest drug besides the 3 immunosuppressive agents?
So proton pump inhibitor.
Pardon?
Proton pump inhibitor.
Proton pump inhibitor. Why do you give a proton pump inhibitor to every patient?
Mostly because they are on steroids. So
I don't believe in doing that. Some people may, but I don't. This is a 5 milligram dose of steroid. So I wouldn't like to give proton pump inhibitors to, in my opinion, we waste a lot of PPIs, unnecessary prescription. So what is the commonest drug that is there on the prescription?
Calcium tablets.
Calcium tablets. All right. You're trying to protect the bones of the patient. Anything else? What about anti-hypertensive drugs?
Yes, sir. Anti-hypertensive drugs. Yes, sir.
What percentage of transplant recipients are hypertensive?
Sir, pre-transplant or post-transplant?
No, post-transplant.
Sir, around 80-85%.
Yeah, so 80-85%, if they are hypertensive, won't you be giving them some anti-hypertensive?
Yes.
So anti-hypertensive is the commonest drug in my prescription.
Yes, sir.
Right? And after that comes an anti-diabetic.
Yes, sir.
Because diabetes, either pre-existing diabetes or no diet. Both of these are fairly common. So therefore, that would be next in order of frequency. Right?
So one question.
Yes.
Sir, would you use an oral hypoglycemic agent post-transplant at the time of discharge in a patient? Or you consider insulin in the initial phase?
In the initial phase, since it is just 10 days post-transplant that we discharge these patients, so I would prefer to keep them on insulin. But subsequently, yes, they can be given an oral drug. There's nothing against that. Yes, your image had temporarily gone. Can you hear me?
Yes, sir.
Okay. So at the time of discharge, I'd prefer insulin, but on subsequent follow-up, if the sugar levels are not very high, I would certainly consider giving oral drugs to these patients. There's no contraindication to using oral hypoglycemic agents in these patients. Yeah. Somebody has been asking what kind of treatment you would offer to a patient like yours.
Sir, like if there is recurrence of primary disease, there is not much we can do, but salt restriction, use of RAS inhibitors, and blood pressure control.
Yes, that's exactly what I would do. Unfortunately, for most forms of recurrent GN, we really don't have any satisfactory forms of treatment. Our treatments are very, very unsatisfactory, and we are able to confirm the diagnosis by a biopsy, but thereafter we are not able to do much. So the situation is very unsatisfactory. So except for RAS inhibitors, controlling hypertension, I really can't offer very much to these patients. In terms of immunosuppression, there is not much else that you can do. You're already giving them triple drug immunosuppression, and changing their immunosuppression or increasing their immunosuppression will not really achieve any responses. In patients with recurrent MGN, people have used rituximab. So that is one option that you can consider using in MGN recurrence. And particularly if it is associated with PLA2 receptor antibody positivity. All right. So, but apart from that, we have very few options. In case of recurrence of ANCA vasculitis, I would stop MMF. I would give endoxin, and I would increase the dose of steroid. Right? So these are some of the things that I would consider doing in case of a recurrence. But apart from these, we really don't have any effective treatments for recurrence. There is a lot of debate about what to do in case of early recurrence of FSGS after transplantation. And people have been using plasma exchange and rituximab in that situation. I can't see you at the moment. Yes. So people have used plasma exchange and rituximab in case of recurrent FSGS, early recurrences. But the responses have not been very good or very consistent. Ultimately, the problem comes back. The only thing good about most of these recurrences is that graft loss does not occur so quickly.
Yes.
So even though you have a recurrence in your patient, hello? Yes.
Yes, sir. Sorry, there was some disturbance. I was just adjusting.
So
yes.
Even though you have a recurrent IgA nephropathy with a creatinine of up to 1.8, this graft may still function for quite a few years, right? So it's not that the graft is going to be lost immediately. So that's the good thing about many of these glomerulonephritides which recur. Recurrence is not synonymous with graft loss. So you can still have the graft surviving for several years. What is the okay? Now we've talked about recurrent disorders. Can you get de novo glomerular disease in the transplanted kidney?
Yes, sir.
So yes. Which de novo diseases
sir,
are common?
Membranous, sir, generally if there is recurrence within first year of transplant, except in cases of FSGS, a possibility of de novo glomerular disease is considered, like membranous glomerulopathy or IgA nephropathy also. There has been suspicion of de novo diseases, though very rare. And
now the first important condition before you make a diagnosis of de novo GN is that you must have a pre-transplant biopsy,
yes,
as you had in your patient. Otherwise, how do you label it as de novo? Supposing there was no pre-transplant biopsy in your patient, you could call it a presumed recurrent IgA,
right.
but you couldn't be sure, isn't it? So to call it a de novo GN, you must have a proven pre-transplant diagnosis and a biopsy post-transplant which shows something different. You get my point?
Yes, sir. Yes.
So, and in that situation, then you call it a de novo GN. Because if you don't have a pre-transplant biopsy, it might be simply a recurrent GN. You can't exclude a recurrent GN in that case. So you can de novo GN, you can get FSGS, you can get IgA, you can get MGN, you can get MPGN. So it's roughly in that order, the frequency. FSGS commonest and MPGN least common. But of course, virtually any glomerulitis can occur de novo in a transplant recipient. Even crescentic glomerulonephritis, for that matter, can occur in a transplant recipient de novo. Okay. Now, just since it's already 8:30, so I'll wind up the bedside quickly now. The only other important point that I'd like to make is when you have a patient presenting with proteinuria with or without a rising creatinine, besides recurrent GN and de novo GN, what is the most important other differential diagnosis that you would talk about?
Sir, chronic allograft nephropathy or chronic ABMR.
See, I don't think you should use the term chronic allograft nephropathy any longer, because that is a term which has been given up because it's a very vague term. It doesn't tell you what is the underlying cause of that damage, right? So yes, somebody has put it up there, transplant glomerulopathy, which we already talked about a short while ago.
Right.
Because when a patient presents with proteinuria, transplant glomerulopathy is the other differential diagnosis which you should consider. Right? Even in this patient, before you got the biopsy, you still needed to consider a transplant glomerulopathy. Remember that he had very low TAC levels.
TAC levels, yes, sir.
And very low TAC levels will predispose to the development of what? Donor-specific
antibodies. Yes.
Antibodies, de novo donor-specific antibodies, yes. And the development of a transplant glomerulopathy, right? So that would be the very important differential diagnosis to consider in this condition. So I haven't, there won't be enough time to cover that area. It will become too lengthy. So I'll stop at this point. I hope you have all of you should have gone through the 2019 BANF update.
Yes, sir.
Yes, because there is a change from the 2018 update. Now there were earlier 6 categories in that BANF classification. Now there are 5 categories.
This I haven't read, sir.
You haven't read. Okay, you can go through that. They have eliminated category 6 which was the others, and they have eliminated category 5, which was IFTA, and now category 5 is simply polyoma virus nephropathy. The first 4 categories are the same. Okay, I won't go into more details of that. You can read up the 2019 update. This has come in AJT.
Okay, sir.
So I'll stop here. If any of you has any questions, we can take those.
So one thing I wanted to ask.
Yes, please.
Sir, should we keep a differential of BKV nephropathy in this patient? Or
for BKV, this is much too late. So I would not consider BKV in this patient. That I would keep it very, very unlikely, because BKV, even if it occurs a little late, it will be maybe by 2 years post-transplant. Beyond 2 years, very unlikely. Beyond 3 years, almost never. Almost never.
Thank you, sir.
Yeah, somebody is asking, does severe anemia have an effect on Tacrolimus levels? I'm not aware of this. Any other questions? Any other points?
Excuse me, sir. I have a question, but not related to this case.
Yes.
Sir, how to manage rapid metabolizers if they are not achieving the TAC levels?
Oh, if they are not achieving TAC levels?
Yes, sir. Yes, sir.
Oh, in that case, I'll consider switching over to cyclosporin.
Okay, sir.
We do have rare patients in whom we are not able to achieve ideal TAC levels, or there is too much of a fluctuation. So in that case, we have generally switched on to cyclosporin. Anybody else? Causes of hypertension post-transplant, somebody is asking. Yes, can you tell us?
Yes, sir. Sir, one is stress, post-operative stress. Then the patient can be fluid overloaded, use of tacrolimus, post-transplant, use of steroids.
Yes.
These are all I can think of.
If a patient has, say, completed, say, 1 year after transplant, he continues to be hypertensive. His graft function is normal, no proteinuria, no rise in creatinine. He was hypertensive pre-transplant. He is now also hypertensive, requiring moderate dose of anti-hypertensive drugs. What is the commonest cause of hypertension? Where are his native kidneys?
Yes, sir.
They are still there inside him.
Yes, sir.
So the diseased native kidneys are one of the commonest causes of hypertension in transplant recipients. So don't forget those. At what and then yes, then any cause of graft dysfunction can be associated with hypertension also. So any of the conditions that we discussed already today, in other words, transplant glomerulopathy, recurrent GN, de novo GN, all these can contribute to hypertension. Okay. And finally, don't forget TRAS.
Yes, sir.
Transplant renal artery stenosis.
Stenosis.
And what is the timing of TRAS usually?
Sir, it is generally early post-operative or even in the early few months. Sir, one is due to clotting early post-op, or there can be due to tight suturing of the transplant artery. When the sutures heal, there can be stenosis.
Yeah, so it's usually at the anastomotic site, and the peak period is something like 6 to 12 months. It can be a little bit earlier than that, little bit later than that, right? The incidence is about 5%. And how do you deal with it?
Sir, it is diagnosed on ultrasound Doppler or an angiography. And
Yes.
then we either do an angioplasty, or we have to, if it is very early, we might need to reoperate.
Reoperation is very difficult. It's usually an angioplasty is the best treatment. Operating again, you know, there is so much fibrosis around the graft, so you should probably never touch it. Just do a angioplasty. That is the best treatment, right? And you should always remember that if you use ACE inhibitors or ARBs and there is a rise in creatinine, always think of TRAS. Right?
Yes, sir.
Any other questions? Somebody is asking about MMF intolerance. Anybody, any other questions? Any last minute questions? Otherwise, we'll close the session here then. Right, then we'll stop here. And thank you very much for your patience. Have taken a long time. And we hope to meet you very soon. Once again.
Thank you so much, sir.
Thank you, Mr. Puneet.
Sir, we can't thank you enough for such an enriching and exhaustive session, sir. Thank you so much.
Thank
And
you.
We'll see you soon, sir.
Much.
Yes, sir.
Right. Thank you.
Thank you, sir.
Right. Bye.